All right, I think we might get going. Good morning, everybody. My name's Michael Boyer, and it's my pleasure to be moderating this webinar on lung cancer as we celebrate Lung Cancer Awareness Month. I'd just like to begin by acknowledging the traditional owners of the land on which we meet. In my case, that's the Gadigal people of the Eora Nation, and pay respects to elders past and present and to any Indigenous people who are joining us today. This session is all about lung cancer and what to expect if you're in the position where you either think or know that you've been diagnosed with lung cancer. And to help us do that, we have an expert panel. I'm hoping that you can see them here on the screen. At least on my screen in the top left, there is Amy O'Donnell, who is a lung cancer nurse. Do you want to wave, Amy, so people know who you are? In the top right of my screen is Jenny Lee, who is a medical oncologist. Down in my bottom left is EeSiang Choong, who's a radiation oncologist. And Corey Lau is in the bottom right of my screen, who is a palliative care physician who spends a lot of time dealing with lung cancer patients. So I hope we're going to have a good conversation about this topic and have some areas of interest. A couple of little housekeeping notes before we get underway. For those of you who are watching and joining, please leave yourself on mute so that we don't have problems with background noise. Secondly, if you'd like to ask questions, please use the Q&A or chat function within Zoom, and I will see those questions and direct them. But we'll start just by a little bit of a discussion, and I'll ask some questions of our panelists so we get a bit of an overview of what lung cancer is and how it's diagnosed. And I thought I might just start with both Jenny and EeSiang, because these are the people that do this a lot. And I was just hoping maybe Jenny to start with, can you just walk us through the process of diagnosis of lung cancer? What is it that happens if someone thinks they might have lung cancer? What happens to them?
So thanks, Michael. So I guess what usually happens, and to paint a scenario to walk you through how the diagnosis is made, an individual may go to their GP with a specific symptom, a scan is done, and if there's a suspicious lesion on the scan, for example, a coin lesion on a chest X-ray, the GP may follow up with a CT scan to characterize it further. And on imaging, if there are lesions that are suspicious of lung cancer, the patient will then undergo a biopsy. And on the biopsy, it will confirm whether this is a lung cancer or not. We also look for sort of various other markers which will help us determine what's the best type of treatment moving forward. And they will also do a PET scan, which is really important for lung cancer to accurately stage the patient, because what we want to determine is whether curative intent treatment is possible or whether we should focus more on systemic therapy with drug treatment. So that's basically a summary. Okay.
Now, I'm just going to ask you, and then I'll ask EeSiang to just explain a couple of the terms that you used. So you talked about a biopsy. Mm-hmm. What do you mean by biopsy? And you also talked about staging. What do you mean by staging? What are those two words mean?
Sure. So basically a biopsy is done to try and obtain a small part of the tissue. So whatever abnormality that we see on imaging, we have to confirm whether that abnormality is in fact cancer or not. And the best way to do that is to get a small piece of tissue, whether it's a needle through the chest or an EBUS, which is an endoscopic bronchial ultrasound, which is a camera down the windpipes and then directly sort of sampling some of the lymph nodes within the chest. And that tissue is then looked at under a microscope in order to confirm the actual diagnosis. In terms of what staging means, staging is to see whether the cancer is early or advanced. There are altogether 4 stages in total. Stage 1 typically means a small cancer. Stage 2, maybe a larger cancer with some, lymph nodes close by. Stage 3, again, cancer with some lymph nodes involved. And stage 4 usually means that the cancer has spread outside what we call local disease, where it's confined to just the primary cancer in the lymph nodes. And sometimes we might find lesions outside the lung or even within the lungs in various places.
Okay, thanks. So EeSiang, so who are all the people involved in this? So, what Jenny just described sounds pretty complicated. I'm sure it's not just something that one person does. So who's involved in doing all these things?
Thank you, Michael. Yes. So that process is actually the initial part of the journey for a lot of our patients before they come to us. So they would have gone through multiple other specialists before they even get to us. Typically, they will, as Jenny mentioned, present to their GP with initial symptoms, and if there were any sort of suspicion from those initial tests, they would then be referred to, I guess, a respiratory physician or sometimes a thoracic surgeon, and they would then get sort of properly assessed through some of those tests that Jenny mentioned in terms of getting a diagnosis from a biopsy confirmation, and then also with further scans like a PET scan to assess the true extent of the disease that we know of at that time. So the patients will have gone through other departments involved in this whole process, including the radiology department and the nuclear medicine department. So they will have been through a lot of various healthcare workers and professionals before they come to us.
Okay, and once that all happens, how's the decision about treatment made? I mean, Jenny mentioned a couple of different things, but who decides what's the right treatment for a particular person?
The cases, like in our center, would typically be presented in the multidisciplinary meeting, whereby there will be a collective sort of decision making with all the healthcare professionals involved in terms of the initial respiratory physician and also the thoracic surgeons, medical oncologists such as yourself and Jenny, and then people like myself, radiation oncologists, and some of my colleagues here as well. And also the radiologists who would then be able to highlight to us the extent of disease involved, and also the pathologists, so the specialists that would interpret the biopsy results for us, and also give us the finer details if there were any sort of driver mutations, for example. And that will all sort of feed into that clinical decision-making process about what is the optimal treatment for that particular patient.
All right. So it all sounds pretty scary, Amy. What do you think? What do you think the patients are feeling? What do you think the person is feeling while this is all going on?
I mean, I think it's all a real big shock usually when they're first diagnosed, especially I think particularly in lung cancer, because often, as you know, people will not have any symptoms. And so they'll be feeling, sometimes they're feeling really well and they're like, oh, you're telling me I've got now lung cancer and it's gone to a few places. And so I guess shock initially happens, I think disbelief, sometimes maybe a little bit of denial, and then often anger happens as well. It's all different emotions that come up. It just depends on the individual as well. Some people do have symptoms and they're not surprised about what's happening, and they've got an answer to what's been actually happening. But yeah, there's lots of different emotions, and it's obviously quite difficult for the patient, not just the patient, but the family as well.
So how do you provide support in that kind of situation?
I guess validating all their feelings is really important, because I think what they're feeling is always appropriate to them. So there's never any wrong emotion or bad, or it's, I think it's allowing them to feel whatever they need to feel and supporting them with the next step. Sometimes just supporting them practically can help them emotionally, because they don't have to worry about the practicalities, or they know that where to go next, and they just sort of take it step by step. But
Right.
everyone's individual and will have different needs, and you just need to try and make it individualized for them and their family situation. Yeah.
Right. And once this sort of process goes on, it sounds like it takes quite a bit of time. I mean, from the time of presentation to the time that something can be done. How Jenny, how long does that usually take?
I mean, I think it can take anywhere between weeks to over a month. So, the initial period to actually seeing the right specialist, which is usually a respiratory physician or a surgeon, followed by a biopsy, is typically a histopathology. From the time when we do a biopsy can take anywhere between a week, and if we add molecular testing on top of that, it can take up to 2 weeks. So yes, it can be a process where there's a bit of waiting involved, and we can absolutely understand that for the patient, each day feels like forever. But we do have a streamlined, very efficient process, and we are trying our best.
Okay. And Corey, you're a palliative care doctor. People often get scared about that because they assume that palliative care, that means they must be dying. Where do you fit into the treatment of lung cancer? Or where does, not just you and your team, actually, I should really say.
Sure. I think the conception that palliative care is just end of life care, that's quite out of date now. I think that used to apply when palliative care first started in the 80s, but now these days palliative care is well integrated into cancer care, and we are a very useful adjunct while people are having treatment. So even if they're just starting chemotherapy or radiotherapy, we can certainly be involved. Because palliative care, I mean, just look at the words. The two big components, there's palliate symptoms and care and support. So any cancer patient, doesn't matter what stage of the journey they're at, they need support, like Amy was saying. They need care and support. Both the patient and the family have got their needs, and we need to address that. And the patient likely is going to have symptoms. I mean, that's probably why they got diagnosed in the first place. So while the oncologist help the patient decide which treatment to go on and support them in their journey, we can certainly be involved in the clinic setting, for example, and make sure that all the symptoms are well controlled and all the other resources are linked in for the patient. So so in Lifehouse, for example, I see a lot of patients with both yourself, Dr. Cow, who also looks after a lot of lung cancer patients. We tend to see them on the same day as they see you, so that you can talk to them about their treatment issues, and then I talk to them about their symptoms and support issues.
Thanks. So, EeSiang, once a diagnosis is made, what's the kind of decision making that goes on around determining the correct treatment, and what are the things that guide or determine what treatment an individual patient can receive?
Thanks, Michael. So I guess the way we would tend to think about this would be what we would call disease-related factors. So that would mean the actual diagnosis itself within lung cancer, what particular type of lung cancer it is, and whether there were any sort of specific mutations, for example. And then there's also the aspect of how extensive the cancer is at presentation, whether it is a very localized area that's involved, whereby decisions such as local treatment with either an operation or local radiation will be enough or curative, or if the disease has extended to other places outside of the chest, then the decision will then be about chemotherapy or systemic treatment or immunotherapy. So that will be the disease-related factors that we look for. The other very important side that we look for really is when we meet the patient and meet the family as well, is really the patient-related factors. So how well the patient is, how old, whether they have any other medical conditions that will impact on the proposed treatment that we have in mind. And also sometimes even very practical things, how far they live away from us, are there any sort of logistical implications in terms of them coming and then being able to comply with a treatment program that we may suggest. So that all builds into that, I guess, final decision making, which is often a shared decision making. The main thing is also really evaluating and sort of exploring the individual patient's intent and goals of treatment. So what would they like to achieve from having this particular treatment? Are we really trying to, go for what we call curative treatment, where we will sometimes accept that they will have side effects, and sometimes these side effects can be quite significant in the short run, but we are really looking for a longer term sort of cure. Whereas in other cases, we may be looking for treatment to really palliate, to improve on their symptoms and provide comfort. And that may not necessarily sort of give any longevity in terms of the benefits from treatment. So all that plays into that whole discussion about the eventual treatment that the patient receives.
Okay. So if a patient's going to have surgery, Jenny, what happens?
They see a cardiothoracic surgeon. So just going back to my previous point of needing appropriate staging, I think, again, the PET scan, which is a nuclear medicine scan, which is very sensitive in identifying especially lymph node disease as well as bone metastasis. So patients are appropriately staged. They then see a cardiothoracic surgeon for consideration of surgery. Occasionally, especially, in situations where patients may potentially be operable, but the cancer may have already gone to the lymph nodes, which is confirmed either using a PET scan or a EBUS biopsy. We may occasionally consider chemotherapy upfront, followed by surgery, or upfront surgery followed by some chemotherapy in addition, which has shown to improve survival.
Okay. And Amy, in your experience, when people have surgery, does it take them a long time to get over it, or is this a sort of a quick thing? What's it like having surgery? And I know I should tell the audience, Amy's not a surgical nurse, but our surgical nurse who was meant to join us this morning has been called away urgently, probably to deal with someone having surgery. But Amy sees plenty of people who have had surgery, so she can answer the question anyway.
Yeah, I mean, I think it will depend on how significant the lung surgery is. And I know that the cardiothoracic surgeons do some keyhole surgery, but they also still do the open, the surgery, the bigger surgery. So I guess it will depend on which they're having, but it's still a significant, at least amount of weeks for them to recover. Sometimes it takes months for surgical pain to go away. And it also depends on how the patient is at the beginning. So if they're really well and fit and healthy and exercise and do all those things and have done for a long time, then obviously their recovery will be easier. But if they're not as well, it can take a longer time.
Okay. And you mentioned pain, Corey. The sort of pain you get after surgery, is that something that's a big problem, or is that something that can be dealt with?
Well, I mean, if they've opened the chest, obviously, then there could be quite a lot of pain post-op. So usually, I mean, in hospital, the acute pain team would be looking after that. But if there's ongoing pain, we can certainly use some different opiate medications, or sometimes it's nerve pain, and we can use medications to manage that.
Right. So it's usually something that can be dealt with.
Yeah.
Okay. So we know that actually roughly a quarter of all patients with lung cancer, with what we call non-small cell lung cancer, which is one of the two big types of lung cancer, about a quarter of all of those people are actually able to have an operation based on all the sorts of things that Jenny and EeSiang were talking about before. Of course, that leaves 3/4 who can't have an operation. Sometimes that's because their cancer has spread very widely around their body. Sometimes it's because their lungs are not good enough to allow for an operation on the lungs, or that there's a little bit too much tumour in the middle of the lungs. EeSiang, there are some new ways of giving radiation that helps at least some of those people, aren't there?
Yes, Michael. So yeah, radiation is certainly a sort of evolving field, and it's very technologically driven. So over the last decade or two, there has certainly been a lot of advancements in terms of the way we deliver radiation, which has both increased the likelihood of cure and also significantly reduced the side effects involved when we deliver radiation. So that particular type of radiation that you were referring to is what we call stereotactic radiation, which is a very sort of precise and localized way of delivering radiation to a very high dose, focused to the tumor, whilst having the ability to spare sensitive organs nearby and hence reduce side effects. In well-selected patients, which are appropriate for this particular type of treatment. In some cases, in some scenarios, the overall results are equivalent to a surgical procedure. So it certainly has made a lot of difference for some of our patients.
Right. And what about combining treatments? I mean, I know Jenny and EeSiang, I know you often give both chemotherapy and radiation simultaneously. Who is that good for? Jenny, you can answer, or EeSiang can answer, I don't mind.
I'll have a first step maybe, and Jenny can correct me. Depending on, I guess, the stage of the patient's cancer, in some patients we would, as you said, recommend a combination treatment, whereby I guess the combined effect of both modalities gives us a better outcome or gives us a better chance of cure. So in those instances, we would typically then deliver what typically will be a relatively high dose of radiation, whereby we intend to get rid of the cancer. And Jenny would also then give chemotherapy as almost a radiosensitizer as well, whereby it augments the effect of the radiation.
Right. And Jenny?
No, I thought that was a great explanation. But I guess the only thing I would add is in those patients who still have a disease stage, which is a little bit too advanced to offer surgery, but then not at a stage where we call it stage 4 or had spread to the other parts of the body where radiotherapy is still an option. Certainly we do add in some chemotherapy, really, as Dr. Choong said, to enhance the effects of the radiation. But nowadays we also follow that by giving 1 year of immunotherapy, which has also demonstrated that it reduces the risk of the cancer coming back as well as extends survival.
Okay, I'll get back to immunotherapy in a moment. Before I say anything else, let me just remind you that I can see there's 20 participants out there, 20 people watching the 5 of us. Can I remind all of those 20 people that if you would like to ask questions, please just type them into the Q&A box. I guess it depends a bit on what sort of computer you're on, but mostly you'll see it near the bottom of the screen. There's a little thing that says Q&A and gives you the opportunity to ask questions. So please ask away, and I can ask our panelists to address them. So what I'll get back to Jenny. I said that I'd come back to immunotherapy. You know, we hear a lot about immunotherapy. It's always in the newspapers. And the other thing we hear a lot about is so-called precision medicine. Are they the same things? Is precision medicine immunotherapy, or are they different things? And what do these words all mean for people with lung cancer?
Look, just to, I think absolutely part of immunotherapy, knowing which patients to give to either alone or in combination chemotherapy, it's all part of precision medicine.
So what does precision medicine mean?
So precision medicine is essentially all stemming from giving the right treatment for the right patient. So no longer is lung cancer considered just one disease. You know, even if we broadly categorize lung cancer to non-small cell versus small cell, which is a diagnosis made by looking at the specific tissue, it's no longer considered as one disease. That's why we do the mutation testing, specifically looking for an EGFR mutation, which some of you may or may not have heard of. We also look for PD-L1 testing, which essentially is a biomarker, again, that we look in the tissue to determine how well a patient may respond to these immunotherapy agents. And then we also look for things like ROS1 as well as ALK, which are rarer mutations. And the reason why we do that is because what we want to do is deliver the best treatment with all the evidence that's out there for the individual patient. And I think that is precision medicine in a nutshell.
Does that help? Does it mean that things are better?
Absolutely. So for example, to give you a quick example, in somebody with an EGFR mutation, what we would absolutely do is give an EGFR inhibitor, also a tyrosine kinase inhibitor, which is essentially a tablet that patients can take every day, which targets that specific mutation in order to shrink the cancer and improve survival. Whereas something like immunotherapy, we would not consider giving somebody with an EGFR mutation immunotherapy first without trying the tablets first. In patients without an EGFR mutation, if their PD-L1 score is really high, we might consider just giving immunotherapy on its own. But if the PD-L1 score is not very high or negative, we will consider combining that with chemotherapy. And like Dr. Choong outlined really well, although we have these optimal, ideal treatment options, it also depends on not just the cancer factors, but also the patient factors as well. Do we think the patient is, well enough? What are their other medical problems? Are we doing the best in terms of tailoring the treatment so we not only extend survival, but also make sure that the patient will tolerate it reasonably well?
All right. Thanks. So, Amy, as a lung cancer nurse, what's your role in all of this? I mean, sounds like there's a lot of things going on for these patients. How do you help them?
Yeah, it's a good question. I think I see my role as trying to support as well as empower patients to make the decisions that they want to make, that are informed. So I think a lot of times in clinic, patients can be told a whole bunch of things. They might be going to a few clinics in one day. And so sometimes I can help them unpack it all, or just help them to understand what's going on, what they need to do next, and make a decision that they're comfortable and happy with. And yeah, so I'm trying my best to support and empower, I think is what I'm saying.
Okay.
Yeah.
And Corey, from your perspective, because again, it sounds like for these people, there's a lot swirling around. And I know it's not just you, it's you and your whole team. How do you provide that kind of ongoing support?
Well, palliative care, we've actually got medical, nursing, and allied health. So we all work as a big team. So I guess how we do it is, well, it depends on where the patient's at in terms of their disease process and how well they are or not. If someone's coming in for chemotherapy or radiotherapy, and they don't have they're still pretty strong, then we would probably see people in the clinic, like I said, hopefully on the same day as they come and see the oncologist, so they get everything done in one go. But as people get a bit frailer and need more support, then we might start getting the community palliative care nurses involved at home as well. And then the idea would be, like I would be seeing the patient every 3 or 4 weeks in clinic, and in between, the nurses can keep an eye on the patients, and the patients can also ring the pal care nurses anytime they need to for advice, and then the nurses can feed back to me and the GP so that everyone's involved in the loop. And then the pal care nurses also act as the case managers, so they would also apart from liaising with me, liaising with the oncologist, the GP, they would also liaise with our allied health team and get them in to the house to look at occupational equipment, or getting social work here in to help with other needs as well.
All right. Now we've got our first question from the audience, and thank you, Anthony, for your question. I'll just read out the question, and it's really one I think that's for Jenny and for EeSiang. The words lung cancer and cure used to be mutually exclusive. Is this still the case? As the new treatments extend outcomes, is there a point at which cure is a reality? And I guess there's two aspects to that question. You can both answer it. One is for earlier stage disease, and the other is for later stage disease. So away you go, EeSiang and Jenny.
Do you want to start, EeSiang?
Okay, thanks, Jenny. Yes, a very interesting question. I think, as oncologists, we are all kind of working towards that world that you're referring to. But I think we're certainly making sort of baby steps towards that. But I don't think it's the reality for all lung cancer patients at the moment. There are specific cohorts, particularly the early stage cancers, that we are achieving cures for these patients. And I guess some of the emphasis is also achieving cure without, impacting on the patient longer term in terms of side effects and the quality of life after their treatment. And some of the refinements that we are making with treatment, both in terms of surgery, like keyhole surgery, recovery time is better, post-operative longer term sort of chronic chest wall pain, etc. is better. And the same applies to, I guess, what we talked about with stereotactic radiation as well. We are able to deliver ablative, curative doses of radiation in a very precise manner, which also then reduces the risk of any longer term complications for the patient. So we're certainly making improvements in that direction. However, there's still a lot of unmet needs, I guess, in patients perhaps in more advanced diseases where, we are again making baby steps, but perhaps not quite achieving that cure word. I don't know, Jenny, if you want to add anything to that.
Yeah, thanks, EeSiang. I think you summarized it really nicely. I think certainly I can speak from the point of view of stage 4 cancer, which, is essentially a cancer that's incurable, and any treatments that we do offer in that setting, except for a select few specific cases, is all quite palliative, and the aim is to improve quality of life as well as possibly extend survival but never achieve cure. I think, having said that, Dr. EeSiang brushed upon it. We now have these newer treatments that are constantly out in the media. There's lots of attention about it. You see these patients who have been on treatment for years, who are doing really well. It then becomes a philosophical question. At what point do we call this cure? I don't think we can ever call it cure. I think we can, however, call it long-term, durable control of the disease. So it's become more like a chronic disease. But then I also want to reiterate that does not necessarily apply for everybody. It's only, we have this select group of patients who do exceptionally well with the newer treatments, but there's still so much more that we need to do. We need to better identify these patients. We need to improve the outcome, as well as the efficacy of the drugs that we have. Using it alone, I think clinical trials plays a big part in moving forward. So to go back to what Dr. EeSiang said, we are making baby steps. We are making improvement. We are definitely making stage 4 cancer a chronic disease for a select number of patients, but we're just not there yet to actually say, we are achieving cure.
I might just add to that. So for people with the kinds of lung cancer that can be operated on, and like I said, that's about a quarter of all lung cancer, the majority, and by which I mean more than half, of those patients will be cured. That, of course, really then highlights the question of how do you find more of those patients? And so there's a lot of discussion about lung cancer screening, and there's been a sort of a big piece of work done over the past year looking at how a lung cancer screening program might be introduced in Australia. There's a response awaited from the government about that, but it seems very likely that sometime in 2021, that will be announced, and whether it starts in 2021 or in 2022, it's coming. And that will probably result in more people with lung cancer being identified at an earlier part of their disease, so increasing the chance of being cured. So thank you for that question, and please others keep asking. We're eager to answer your questions. So Jenny, you said you'd come back to immunotherapy. You touched on it a little bit. What is immunotherapy, and why is it interesting? Why does it get all the hype that it seems to?
Look, Michael, I mean, that's definitely my area of interest. I think there's no doubt that immunotherapy has revolutionized the way we treat cancer. And I think specifically, and the immunotherapy agent with the most amount of data, with the most widely used at the moment, are the immune checkpoint inhibitors. So using immunotherapy is basically boosting or strengthening the individual patient's own immune system to attack the cancer. But it also relies on the fact that your own immune system is actually recognizing that the cancer is foreign. So what the immune system constantly tries to do is eliminate foreign things, for example, like infection and cancer. But unfortunately, because the cancer is quite smart and it evolves in a way to evade the immune system, it just needs that extra bit of help with these treatments that we have, like the immune checkpoint inhibitors, to then re-identify the cancer and to kill it. So certainly it's demonstrated good responses in lung cancer, but also in cancers such as melanoma, as well as head and neck cancer and bladder cancer. And with lung cancer, like I said before, not everybody has a really great response to immunotherapy. For example, the EGFR mutant patients, they tend to start with tablets first. And we also look at PD-L1 staining, again, like I said, is a biomarker to determine how well the patient will respond. And we think that probably has something to do with the amount of mutations that the cancer has, that the immune system recognizes as being foreign. There's definitely more work moving forward to determine which patients will do best and what sort of combinations we can use to enhance the effects and improve responses. But that's basically immunotherapy in a nutshell.
Okay. So when people are having immunotherapy, Amy, what sort of help or support do they need?
I guess when they are having immunotherapy, it's always, of course, when you have any drug, it's always good to be aware of what it is and what the side effects are. So ensuring that patients understand what they're having. It's also good for them to know who to contact if they have any issues, because immunotherapy is very different to chemotherapy. Chemotherapy usually has really predictable cyclical side effects, whereas immunotherapy, often some people will sail through it and some people will have really bad inflammation issues and need to be admitted to hospital. So it's just making sure that they're aware of potential, especially risky, life-threatening side effects, and more importantly, who to call, because often they can be confusing and they can be quite complex. So it's just ensuring that they have the contact details of who to contact if they've got any issues.
Okay. So we've obviously talked about a fair bit of cancer, a fair bit of lung cancer. I guess there's a couple of slightly scary topics, but important topics that I would like to touch on. We've talked about the good things and all the things we can do to try and cure patients and keep them alive and well for long periods of time. But I guess there's a reality that when you're diagnosed with lung cancer, some people, in fact, many people, ultimately die as a result of that disease. Corey, what do you think are the important things that are involved in looking after people as they get towards the end of their life? And how do we make decisions that if you like, look after patients and look after their families in that situation?
Well, I think firstly to say every patient and the family situation is different. So I think as the patient's not doing so well, I think we need to make sure that the patient and the family understands where things are at. And then we need to have a big discussion about what to expect from here and what are their goals and what are their wishes. Because I think you talk to a lot of people, and a lot of people might say they want to die at home when the time comes. But when I hear that, I would then look at, you know, the family and see if that's actually going to be possible. Because I guess for someone who's getting very sick to stay at home, they actually need a lot of hands-on support. So in terms of resources, sure, we've got our the community palliative care team, we get home care, but then a lot of the patient's care needs is still going to be attended by the family. And not, I mean, when I first started working in palliative care, we used to have big families that can come home and help the patient and to stay at home at the end. But these days, you know, things are different. People have big mortgages, they can't take a lot of time off work. So, you know, you may end up with not enough pairs of hands available for the patient to stay at home when they get really, really weak. So that's something we need to have a think about early on to see what's the family's wishes, what's actually possible, and if it looks like it's actually not possible for the patient to stay at home at the end, then we would talk about the availability of our palliative care units as a backup. So our palliative care unit in the Sydney Local Health District is at Concord, and I know that there would be people that's joining Zoom that doesn't live in our area. So each area, each local health area would have their palliative care ward in the particular hospital, I guess. So the local palliative care team would be discussing with the families and the patient when the time's appropriate, where the resources are.
Okay, thank you. And can I just welcome Andrea, who was tied up a little earlier, but there she is. You can tell she's a surgical nurse because she's wearing a mask.
I just took it off. Hello. So sorry, very sorry I'm late.
That's okay. That's okay. We've been having a very good discussion. Amy filled in for you and told us what it was like to have an operation, but we might just ask you now, what when you see someone with lung cancer who is kind of lining up to have an operation for their lung cancer, what are the things you go through and what do you telling them that they should expect?
Okay, so if I'm meeting a patient after a surgeon has met them who has been consented for a lung operation, then I will sit down with them one-on-one or with the family, of course, and talk about the operation itself and the techniques used for the operation. So we talk at length about whether it will be a minimally invasive operation or a open approach, which is determined by the review from the surgeon and the imaging and the patient's the individual patient. And then we talk about the next steps in terms of other tests that need to be organised, whether that be lung function tests, further CT scans or further PET scans for surgical planning, and the pre-admission clinic where they go through all the rest of the tests that we need for the operation, the blood test, the anaesthetist review, and the physiotherapy review, which are all very important factors prior to having a lung operation. And then I very much talk about what it's going to be like once they wake up in recovery after the operation, because they're going to have a chest drain, a large tube coming out their side between their ribs, which is inserted at the end of the operation at the surgical site to drain any air or fluid that may be leaking from around the operative site. And I very much talk about how important pain relief is after the operation, as well as the physiotherapy. So we talk a lot about the pain relief regimes that we use, the patient control pain button and the paravertebral catheter providing the local block. That's a small catheter that sits in the back. and the importance of very early mobilization as well. So it's very much a matter of after the operation, the physios will see you in the afternoon on the ward and talk about deep breathing and coughing techniques, which are very important to expand your lungs, help get the oxygen all the way to the bases. And then the importance of sitting out of bed the very next day and using your pain relief button as well. We talk a lot about length of time in the hospital as well, and what to expect when they go home. So as I said, physiotherapy is such a large part of that and a component of your recovery after lung surgery as well. So that's a lot of education while the drain is in, but a lot of education about what people can and can't do when they get home as well. A lot of people worry that they're going to hurt something inside their chests by doing too much exercise when they get home, which is very much not the case. We certainly don't advocate for starting weightlifting in the gym straight away or anything like that. But certainly resistance and stretching exercises are a very important part of your recovery at home as well.
And just a quick one, and I know the answer to this, but I want you to say it. Does it matter if you smoke before an operation?
It very much does matter. We have a requirement that a patient does not have a single cigarette for at least 4 whole weeks, 4 to 6 weeks ideally, but at least 4 whole weeks prior to actually having an operation. And the reason for that is because it can cause respiratory issues after the operation, pneumonias, your chest drain could end up staying in for a lot longer and things like that. So we want your lungs to be in the most tip-top shape that they can be prior to undergoing this operation, which is to remove a part of your lung.
And EeSiang, what about you? Does it matter if you smoke while you're having radiotherapy?
Yes, absolutely. I think there's a good amount of data to say that smoking does impact on the overall efficacy of radiotherapy treatment overall, and it certainly doesn't help with any sort of functional lung in terms of your physiological reserve, because with radiation we will be damaging some part of functional lung as well. So any sort of reserve that you have that you can preserve, which smoking is contrary to, actually smoking damages any sort of functional lung. So that in itself is not good. So overall, don't smoke when you're having radiotherapy.
Okay. And Jenny, what about chemotherapy and immunotherapy?
Oh, I mean, I can't go as far as to say that it affects the efficacy of the treatment that we give directly or increase the amount of toxicities, but certainly there is lots of data to suggest even in the stage 4 setting, quitting smoking is definitely beneficial in terms of survival and outcome.
So for the audience, I think the message is pretty clear. If you smoke, you should stop. That's actually probably a good piece of advice, whether people have lung cancer or not, because we know that smoking actually is bad for you, whatever your health status. Now, just one last call for questions. We don't have any questions waiting at the moment, so this is your chance to get in. You'll go straight to the front of the line, and we will answer. Oh, look at that. Here we go. Perfectly on cue.
Can I just interrupt and say that if anyone is smoking and they are wanting to quit, then please get in touch, because we've got a good referral service. So if they need to, they're thinking about stopping and they can get in.
So Amy's your girl for stopping smoking. Jenny, there's a question here. What does a PD-L1 score tell you about the cancer itself? Is it an indicator of how well the cancer is hiding from the immune system, for example?
Look, I think all of that is correct. In fact, PD-L1 is a receptor which is expressed on the surface of the cancer cell. And in fact, what leads to the highest upregulation, so PD-L1 is not a receptor that's always there, and it sort of gets upregulated and expressed on the surface of a cell as a response to inflammation within that vicinity. So I think it is reasonable to say that PD-L1 is probably an indication that at one point the immune system had recognized that the cancer was foreign and tried its best to eliminate it, but didn't succeed. Whether it's a marker of how well it's evading the immune system, I think that is in part correct as well.
Okay, and how do we use it? Do we use it to choose treatments?
Absolutely. So going back to requiring a biopsy diagnosis to accurately determine which treatment regimen is ideal for the individual patient, we also look at this thing called the PD-L1 tumor proportion score. So what we do is on the slice of tissue, we look at how densely the PD-L1 is expressed on the cancer cells. And for example, if more than 50% of cells are expressing the PD-L1, I think we've got a pretty good idea that that particular tumor will be quite responsive to immunotherapy. I think if it's less than 50%, and it is sort of, I agree that it can be a bit of an arbitrary cutoff, but that's how the clinical trials were designed. So if it's less than 50%, what we might recommend is immunotherapy in combination with chemotherapy, for example. Okay. So we absolutely use that to determine, you know, what sort of treatment we give.
So while we've been talking, another couple of questions have come in. One is that with melanoma that has spread to the lungs, are the treatments the same? And I assume that means the same as lung cancer. So I might ask EeSiang to just address that. So is melanoma spread to the lungs kind of the same as lung cancer?
No, so I guess the way that we view it will be they're separate entities altogether. They're very different disease processes altogether. Their natural behavior and the pattern of behavior is very different. So we would consider them very different entities. And their treatment as a result will be very different as well.
Although actually, as it turns out, it may not be that different, because if there's one thing there, we might take it out, and if there's more than one thing there, we'd give immunotherapy. So, but what EeSiang says is correct in the sense that a cancer that starts somewhere else and spreads it spreads to the lungs is not lung cancer. It's still melanoma, or if it had started in the breast, it's still breast cancer, or if it started in the bladder, it's still bladder cancer, even if it's in the lungs. It just so happens that in the example of melanoma, the treatments might turn out to be, by accident, more or less the same. So Ted has asked a very interesting question and a very complex one to answer, but we'll get Jenny to have a go at it first. What causes metastasis of cancers? Why do cancers metastasize?
Wow, that's a difficult question. I think, you know, just to give an example of
and what is it? So do you want to just describe what do we mean by metastasis? What fundamentally, what are we talking about here?
So I think biologically, what the cancer is designed to do, due to various mutations that either drive the cancer, or in mutations that affect the function of stopping the cancer from forming in the first place. What the cancer likes doing is it likes invading. So it first starts with a couple of cells and it starts invading the surrounding tissue. But what it also does is it develops the ability to break off from where it originated and start moving into other organs or regional lymph nodes, for example, and that's how it metastasizes. And the reason why that happens is because it relies on certain oncogenic pathways which facilitate this happening.
Okay, and is there anything you can do to stop that? I mean, is that something that's under our control?
I think the best way to stop that is to diagnose and identify the cancer before that's happened. I think, certainly there are things that we try to do on top of, sort of cutting it out or giving high dose radiation to remove the cancer before it has a chance to metastasize, but also, including chemotherapy to hopefully mop up any few cells that may have escaped. But do we know of mechanisms to stop the cancer from invading and metastasizing in the first place? Not that I know of at this stage, but there's definitely ongoing research in investigating that.
Okay. Look, we are down to the last minute or two of this session. So I'd like to just draw it to a close by firstly thanking all of our speakers. Really appreciate you taking the time to talk with us today, and really appreciate the clear and simple explanations, which I hope has been something that's helped everybody that's watching today. I'd also like to just reiterate that if you happen to be a patient here at Lifehouse and watching, there's plenty of resources for you here. There's plenty of ways of getting in touch with any of the doctors that work here, with the nurses that work here, or with anybody else in the team. And the team is actually pretty big, and that applies obviously to RPA as well. If you're not a patient at Lifehouse, there's almost certainly very, very similar things set up wherever it is that you're being treated. I'm just like to thank you all for attending and for listening to us talk. I hope it's been helpful for you. I hope you've found it interesting and stimulating. And for any of you that are being treated for lung cancer, good luck, and I hope it all goes very well. And with that, I will stop and say goodbye.
Thanks, everyone.
Bye-bye.
Bye.